My topic is psychotropic drugs in overdose, presented by Dr. Shivani Dana, and my moderator is Dr. Anusha Agrawal. What are psychotropic drugs? Psychotropic drugs are chemical substance that crosses the blood-brain barrier and act primarily upon the CNS, where it affects brain function, resulting in alteration in perception, mood, consciousness, cognition, and behavior. Stimulants have methylphenidate, antipsychotics like haloperidol, risperidone, olanzapine, antidepressants like tricyclic antidepressants, SSRIs, SNRIs. Anxiolytics are lorazepam, diazepam, alprazolam, and stilnox. Mood stabilizers are lithium, carbamazepine, valproic acid, and lamictal. Not classified are desmopressin, naltrexone, atomoxetine. Aspirin and other salicylates overdose. Clinical features are vomiting, tinnitus, deafness, sweating, vasodilation, hyperventilation, and in severe cases, confusion and coma can follow. Treatment: there is no specific antidote for aspirin or salicylate overdose, but patients may require intravenous fluids to correct dehydration and enhance salicylate elimination. Sodium bicarbonate may also be used to reduce transfer into the CNS and to alkalinize urine and enhance salicylate excretion. Opioids overdose. Features are respiratory depression, pinpoint pupils, hypotension, reduced levels of consciousness, coma. Obtundation may also result in rhabdomyolysis. Treatment: beyond an ABCD approach, where the patient is unconscious or bradypneic, that is respiratory rate less than 10 breaths per minute, not intravenous routes may be quicker because time is saved in not having to establish access, which may be difficult in patients who regularly use intravenous recreational drugs. Naloxone may be given via IV, intramuscular, subcutaneous, and intranasal routes. The initial dose of naloxone are 400 microgram IV, 800 microgram IM, or 2 milligram intranasally, while ensuring that the airway is protected and supporting breathing, giving increments of naloxone every 2 minutes until the victim is breathing adequately and has protective airway reflexes. For intranasal naloxone, if the patient responds to first dose but relapses rapidly into respiratory depression, give the second dose immediately. Large opioid overdoses may require titration to 10 mg naloxone. And tricyclic antidepressant overdose. Features are dry mouth, dilated pupils, urinary retention, reduced consciousness, coma, hypotension, hypothermia, hyperreflexia, extensive plantar responses, convulsions, respiratory failure, metabolic acidosis, QRS prolongation, potentially leading to life-threatening arrhythmias. Management is supportive in an acute medical or intensive care environment. Intravenous sodium bicarbonate is given to treat the metabolic acidosis. Antipsychotics overdose. Features are altered mental status. Altered mental status, urinary retention, tachycardia, dry mucosal membranes, hyperpyrexia. Acute dystonic reactions can occur. Hypotension and QTC prolongation may also be observed. All antipsychotics lower the seizure threshold, particularly clozapine. Management: supportively manage in medical environment. Patients with CNS depression may require intubation. Patients should be monitored for QTC prolongation. Prophylactic anticonvulsants may be considered if not contraindicated and where the seizures are threatened. अब चल रही है heavy. सुनता रहना तो कौन सुन रहा है? Lithium overdose. Features are apathy and restlessness, followed by vomiting, diarrhea, ataxia, weakness, dysarthria, and tremor. There can be a delay of up to 24 hours in the emergence of symptoms in lithium-naive patients. In severe poisoning, confusion, coma, dehydration, renal failure may occur. Lithium toxicity is more common in patients on chronic lithium treatment. Treatment is beyond an ABCD approach, in increasing fluid intake and intravenous fluids to aid clearance, although forced diuresis is contraindicated. Hemodialysis may be required in severe cases. Benzodiazepine overdose. Features are drowsiness, ataxia, dysarthria, nystagmus, and sometimes respiratory depression and coma. Treatment: antidote of benzodiazepine is flumazenil. which is a competitive antagonist at the benzodiazepine binding site on the gamma aminobutyric acid A receptor. Initial IV dose 200 microgram over 15 seconds. Further, 100 microgram can be given every minute to a maximum of 1 milligram. However, however, its use can be hazardous because it risks precipitating seizures and ventricular arrhythmias. It is contraindicated in mixed overdose and in those with benzodiazepine tolerance, seizure disorders, or prolonged QTC. Stimulant overdose features are euphoria, wakefulness, and excessive activity, but can lead to delirium, coma, convulsions, arrhythmias. क्या क्या था? फोन किस लिए तेरे पास? रुक जा, एक लास्ट स्लाइड अपन ले लेना इनको. Features are euphoria, wakefulness, and excessive activity, but can lead. मैम ने कहा कंटिन्यू करते हैं. संजीव ने हो गया. अच्छी कि नहीं हो गया. Features are euphoria, wakefulness, and excessive activity, but can lead to delirium, coma, convulsions, arrhythmias, hyperthermia, rhabdomyolysis, acute renal failure, acute hepatitis, disseminated intravascular coagulation, adult respiratory distress syndrome, and intracerebral hemorrhage. Treatment is patient with core body temperature above 38 degrees Celsius may require active cooling. Benzodiazepines such as diazepam or lorazepam may also help. My reference is Model 3 practice guideline 14th edition. Thank you. मैम करेगी, मैं बोल देगा. ये अच्छा मौका था ना.
My topic is psychotropics and surgery, presented by Dr. Akash Thomas, and moderator is Dr. Abhishri Ranjan. Overview: introduction, anti-seizure drugs, antidepressant drugs, and antipsychotic drugs, benzodiazepine drugs, lithium drugs. Now we will discuss about these headings in next slides. Introduction. Patients are at risk of aspiration their stomachs contents during general anesthesia. For this reason, they are usually prevented from eating for at least 6 hours before surgery. However, clear fluids leave the stomach within 2 hours of ingestion, and so fluids that enable a patient to take routine medication may be allowed up to 2 hours before surgery. There are some interaction between drugs used during surgery and routine medication that constitute an absolute contraindication. This is usually managed by anesthetics through their choice of anesthetic drugs. but may involve temporary cessation of regular medication. Significant interactions between medicines used during surgery and psychotropics, including the following. Influence may precipitate seizures in patient taking tricyclic antidepressant. Pethidine and other serotonergic opioid may precipitate fatal excitatory reaction in patient taking MAO inhibitors and cause serotonin syndrome in patient taking SSRI. Volatile anesthetics like halothane, enflurane, etc. prolong QTC and should usually not be given to QT prolonging drugs who have ECG evidence of QT prolongation. In addition, major surgical procedure include profound physiological changes, which include electrolyte disturbance and the release of cortisol and catecholamines. Post-operatively, surgical stress and some agents used in anesthesia may lead to gastric or gastrointestinal stasis. Oral absorption of drugs is therefore likely to be compromised. To continue or not continue. For the most part, psychotropic drugs should be continued during the pre-operatively periods. Now we will discuss about anti-seizure drugs. CNS depressant activity may reduce anesthetic requirements. Drug level monitoring may be required. Reduced dose of propofol may be required. Has been used pre-operatively and has analgesic properties. Safe in surgery, probably use continued for people with epilepsy. Now antidepressants. First one is MAO inhibitors. Dangerous, potentially fatal interaction with pethidine and dexamethasone. Serotonin syndrome or coma respiratory depression may occur. Sympathomimetic agents may result in hypertensive crisis. Avoid ketamine, ephedrine, pancuronium. MAO inhibitor lasts for up to 2 weeks. Early withdrawal is required. Switching to moclobemide 2 weeks before surgery allows continue treatment up until day of surgery. Do not give moclobemide on the day of surgery. Probably not, but careful selection of anesthetics agent may reduce risk if continuation is essential. Now SSRIs. Danger of serotonin syndrome if administered with pethidine, fentanyl, pentazocine, or tramadol. Occasional seizures reported. Sedation may result in withdrawal syndrome and increased risk of relapse. Rule out hyponatremia in all surgical patients. Venlafaxine may provoke opioid-induced rigidity, increased risk of perioperative bleeding, probably, but avoid other serotonergic drugs in the surgery. Now tricyclics. Danger of serotonin syndrome if administered with pethidine, pentazocine, or tramadol. Many drugs prolong QT intervals, so arrhythmia more likely. More drugs lowers seizures threshold. More lesser core hypothermia. Sympathomimetic agents may give exaggerated response. Effect persists for several days after sedation, so will need to be stopped sometime before surgery. Unclear, but anesthetic agents need to be carefully choose. So authorized recommended slow discontinuation before surgery. Antipsychotic. Some antipsychotics widely used in anesthetic practice. Increased risk of arrhythmia with most drugs. More enhanced intraoperatively core hypothermia. Clozapine may delay recovery from anesthesia. Gases anesthetic may affect dopamine metabolism. Preoperatively, olanzapine reduce risk of delirium and may preoperatively aripiprazole. Aripiprazole. Use of SGA may reduce postoperatively nausea. Probably usually continue to avoid relapse. Benzodiazepine reduce requirement for induction and maintenance anesthetics. Many have prolonged action, so early withdrawal is necessary. Withdrawal symptoms possible, but usually continued in surgery. Lithium prolongs the action of both depolarizing and non-depolarizing muscle relaxant. Surgery-related electrolyte disbalance and reduced renal function may precipitate lithium toxicity. Avoid dehydration and NSAIDs. Possible increased risk of arrhythmia. In surgery patients, probably safe in minor surgery, but usually discontinued before major procedure and restart once electrolyte normalize. Slow discontinuation is necessary. Anesthetics may not precipitate this. Reference by Maudsley, Prescribing Guidelines in Psychiatry, 1430s. Thank you.
Good morning, everyone. Myself, Dr. Vaibhav, going to present the presentation on kidney transplant and psychiatric implications. First of all, we will talk about the psychopathological aspects of kidney transplantation. Renal transplantation is a well-established treatment for the end-stage renal disease. Kidney transplantation is a very challenging for the patient and act as an intense stressor stimulus to which the patient reacts with neurotransmitter and endocrine metabolic changes. The transplantation can result in a psychosomatic crisis that requires the patient to mobilize all biopsychosocial resources during the process of adaptation to the new foreign organ, which may result in an alteration in self-representation and identity, with possible psychopathological repercussions. For example, post-traumatic stress disorder, adjustment disorder, and psychosomatic disorders. The correlation of patient anxiety after kidney transplantation, the interconnection between psychological and physical functioning in patients after transplantation. The present study examined the impact of anxiety on vocational rehabilitation and its relationship with the functional tests. A total of 100 patients after kidney transplantation underwent functional tests, including the 6-minute walk test, 30-second chair test, and psychological tests, specifically the inventory of physical activity objectives, workability index, and state train anxiety inventory. Working ability was affected by psychological factors. State and trait anxiety exhibited inverse relationship with the subject readiness to occupational activity. The level of anxiety was negatively related to the result of the 30-second chair stand test. This is how it's done. Psychological functioning and psychosocial issues in pediatric kidney transplant. Pediatric kidney transplant recipients are more susceptible to mental health concerns such as depression, anxiety, and ADHD, as well as developmental and neurocognitive delays compared to the health parents. Complex medical care and psychosocial needs for the patient have implications for family functioning, parental, sibling mental health, and youth readiness to transition to adult care. Depressive symptoms are also associated with the sleep in kidney transplant patients. Both depression and sleeping complaints are very prevalent among the kidney transplant recipients. However, details of complex relationship between sleep and depression is there. 95 kidney transplant recipients participated in the study. Symptoms of depression were assessed by the Center of Epidemiological Study Depression Scale. The Center of Epidemiological Study Depression Scale was significantly associated with the amount of stage 2 sleep, rapid eye movement latency, and rapid eye movement percentage. Depressive symptoms among the kidney transplant recipient are associated with increased amount of stage 2 sleep and prolonged REM latency. In kidney transplantation, the fruitful collaboration between the professional with diverse scientific expertise call for both a guarantee for mental health and greater effectiveness in challenging and viable association between patient, family, member, and doctors. Integrated and multidisciplinary care should include uniform criteria and procedures for standard assessment for patient autonomy, adherence to therapy, and new coping strategies, and adaptation of more appropriate lifestyle. It is important to carefully monitor the patient functioning and empirically validate the tools, and to intervene in multidisciplinary settings as early as possible to identify the patient at risk and reduce the potential negative impact. My references are these. Okay.